Okay, this is a short video that talks about food-drug interactions. This is an important topic to learn about because you will be seeing food and drugs in your hospital environment every single day. So I want to briefly introduce this concept to you, talk about the people and patients who are most at risk of experiencing food-drug interactions, and then commonly encountered food-drug interactions, so you can be on the lookout for those. So food-drug interactions and drug-nutrient interactions, these terms are sort of used interchangeably. They are different, and I'll show you that right now. So the definition of a food-drug interaction is it's just this broad term that includes the effects of a medication on nutritional status. So certain drugs may increase or decrease your ability to absorb or excrete certain nutrients, and that may have an effect on your nutritional status. A drug-nutrient interaction is a little more specific in that it's looking at specific changes to the pharmacokinetics of a drug caused by a nutrient or nutrients, or changes to the kinetics of a nutrient caused by a drug. So could be the drug, could be the nutrient. But just to define or help you understand what pharmacokinetics means, that's a term used by pharmacists that really refers to the study of how the drug is absorbed by the body, distributed, metabolized, and excreted. And oftentimes we're interested in how long that takes, how quickly it's the most active, how long it takes to get rid of it out of the body. Pharmacodynamics is the study of the biochemical and physiological effects of a drug. So in that case, we're more interested in what the drug does and what the effects of that drug really are. So the two terms, like I said, are sort of used interchangeably. They are different, as you now know. But for this class, we'll talk about food-drug interactions because it's the broader term. So food-drug interactions can be quite extensive and complicated. To show you an idea of that, sorry for the grainy picture, but Coumadin is the brand name of a drug called warfarin, and it is an anticoagulant. So people who have had clotting problems, perhaps they've had a stroke, pulmonary embolism, anybody that needs to make sure that their blood is not going to clot or coagulate might be on a blood thinner like this particular drug. It is an older drug, and it is kind of going out of fashion, I guess, because it has the potential, if I can show you, to interact with a lot of nutrients, foods, and so on. So there are interactions with warfarin and fatty acids, vitamin K especially, and then a variety of nutritional supplements that your patients may be consuming because they think they're healthy. So if you have a patient on this particular medication, you would really want to know what other nutritional supplements or medications they might be on to see if anything's going to interact. Now, this isn't your primary job, but really the pharmacist should be working with you, but you may be asked to do education on the food-drug interactions that people might encounter. So there can be both short and long-term effects of food-drug interactions. That medication I just showed you, warfarin, it's designed to keep the blood from clotting. What does vitamin K do? It clots the blood. So you can see these two things are going to have opposite effects. So what we tell patients that are on this particular therapy is that they need to keep their intake of vitamin K-rich foods very consistent over time, because there can be problems with the medication not being as effective as it needs to be for their optimal health outcomes. Another example for a longer term effect would be corticosteroid use, and that's often used to reduce inflammation in the body, and long-term use of those can result in osteoporosis. So going back to this idea of pharmacokinetics and how it is important when we think about food-drug interactions, remember pharmacokinetics talks about absorption and distribution of drugs. So we know that the absorption of drugs can really be affected in some cases by the gastric emptying rate, so how quickly things are leaving the stomach, and GI transit time. So oftentimes you'll see medication instructions that the medication should be eaten on or consumed on an empty stomach or with food, and those are very important directions to pay attention to. In the example of thyroid medication, should be taken on an empty stomach at least 30, if not 60 minutes before eating, because any of the food or even coffee, tea, things like that will decrease the absorption of the medication and make it less effective. Distribution of the drug talks about where it's going in the body and what effects it might have on those targeted areas. So we know that drugs are transported through the blood, and in order to do that, they have to use transport proteins. Albumin is a major transport protein, and what's happening is as the drug moves through the system, it's being transported by these transport proteins, but really the part that's really effective are the unbound portion of the drug that's circulating. So if you've got fewer transport proteins in the case of a low albumin, then you're going to really increase the effect of the medication because more of it will be unbound. Pharmacokinetics also talks about metabolism of the drug, and this is really heavily dependent, so detoxifying or going and processing medication that you take is really the job of the liver. And if there's some sort of liver problem, that's going to cause a problem with the effect of the drug. There are also the gut microbiome or the gut microbiota can change the metabolism of certain drugs, so how quickly they're metabolized, how slowly, and those can change how we expect the drug to act in the body. We also know that certain mineral statuses can decrease drug metabolism, so calcium, magnesium, and zinc are important for the drug to be metabolized so it doesn't hang around and continue to work longer than we want it to. Vitamin C deficiency also can prolong the activity of the drug because it's reducing enzymes important for metabolizing and sort of getting the drug to where it can be used and then excreted. And then excretion is part of pharmacokinetics as well. Most drugs leave via the urine, and dosages are typically given for people who have healthy liver and kidneys. And if you don't, then the doses often has to be recalibrated or refigured to make sure that we're not giving people too much or not enough. Who's at the highest risk for food-drug interactions? Probably older adults. This is because they are taking a lot of medications. That's what polypharmacy refers to. They may have some cognitive dysfunction, so they can't remember if they took their medication or how to take it properly. They may have poor intake, so that could influence the metabolism of the and absorption of the drug. And then they often have lower albumin, so that might make the drug more effective. And more of something always isn't always good, right? People who are undernourished will have differences or alterations in the amount of muscle versus fat mass that they have. And if a drug is a fat-soluble drug, then that lack of fat mass may result in a reduced effectiveness of the drug. And then in obesity, of course, we would see the opposite effect, right? People that have certain disease states can also be at greater risk for food-drug interactions. There are a lot of HIV and cancer medications that have very well-known food-drug interactions, and if you go into those areas, you will become an expert on those. Anytime we've got vomiting, diarrhea, any kind of altered GI transit, things may be going through slowly or not at all, more quickly or not at all, and that can cause obviously problems with pharmacokinetics. Liver and kidney disease, like we said before, we assume that doses are given to people who have good working liver and kidneys, and if they don't, then there's a risk that those drugs will continue to circulate and not be cleared from the body. There is more and more work being done on how your genes can affect how you metabolize certain medications, and this is really an interesting area of study. Certain medications won't work for people with certain gene types, or they work in different ways, or are less effective or more effective. And so as we learn more about genetics, we may be able to tailor your medications a little more personally for your exact needs. People who take nutritional supplements, I showed you the warfarin website. Unfortunately, we don't know what's in those nutritional supplements. It could be what's on the bottle. It could be none of the above. It could be something that's actually a real drug. It could be a contaminant like a heavy metal. So all of these things can cause problems with the medications that people need to take. St. John's wort is a very good example of a nutritional supplement that can interfere with a lot of medications. The effect of food on medication, I mentioned this a little bit, the bioavailability, or what's actually able to be used by the body and enters into circulation, can be dramatically altered if food is consumed with it. So like I said, Synthroid or levothyroxine, basically the absorption of that is way, way less if you've got any food or even beverage in your stomach. So that's the long and short of it, I guess. It's also important to realize that certain nutrients can bind with the medication and prevent absorption, and gastric pH is important in some cases for the medication to be broken down and absorbed. And so when you interfere with that pH by perhaps eating and increasing your gastric pH, it might mean that the medication is not broken down. And we usually recommend iron supplements taken on an empty stomach with water. That can be really difficult for a lot of folks because iron supplements can cause some GI distress. So I have thoughts on that. If you want to get some tips, you can ask me in class. In our particular class, we don't have any sedated patients or ICU patients for the most part, but there is a particular sedative that is really, really, really high in fat, and we need to think about what it's doing in terms of the energy that it's providing for us. Phenytoin or Dilantin, individuals with epilepsy are often prescribed this, but it's another case where we cannot give food concurrently with that medication, and so it's kind of easy to think about if they were using it as a pill, but if we're tube feeding them, then we have to hold the feeding for 2 hours before or after administration of that medication. And then patients often, if they're on that medication, need additional folate because the body stores of folate are depleted by that particular medication. Megestrol or Megace is an appetite stimulant that you might see given to usually cancer patients, but if we can't do it if they've got diabetes, because it can really, really cause blood glucose to increase. And you'll even see it in people without diabetes. It also increases liver enzymes. So when we think about I don't know if it's necessarily a food-drug interaction, but it's certainly a drug interaction that's going to have nutritional effects, potentially. Methotrexate, anti-cancer, anti-arthritis medication will also decrease folate absorption, so people might need to really focus on that in their diet or use a supplement. And then alcohol inhibits thiamine utilization, so oftentimes if you see people admitted for chronic alcoholism, they do benefit from thiamine repletion. We'll go on just a couple more here. There's a certain class of medications used for depression that are called monoamine oxidase inhibitors, or MAOIs. And what they do is they help to promote the rate at which serotonin and dopamine are removed from the brain. There are a number of different drugs that fall in this classification. They're in that third bullet point there. I'm not going to try to trip over my tongue and pronounce them all. But the take-home message for the dietitian is that foods that are high in the amino acid tyramine can interact with these MAOIs and actually generate or precipitate a hypertensive crisis. So really high blood pressure, which can of course lead to stroke. So the recommendation, if you see anybody with these, and they're kind of going out of style as well, we have other medications that help with depression, but they should avoid aged foods like some of the aged cheeses that are available, sauerkraut, cured meats, draft beer, fermented soy products like soy sauce, miso, and tofu, because these are all foods that are high in tyramine. Serotonin syndrome can occur when taken with other antidepressants, so that includes a natural, herbal supplement like St. John's wort. And serotonin syndrome is characterized by anxiety, agitation, sweating, confusion, tremors, and tachycardia, or rapid heart rate. And then weight gain is a side effect of these medications as well. So you might see patients who put on 20, 40, 60 pounds after they've started their MAOI. So we'll talk in class about some of the statins, but there are some interactions with grapefruit and other citrus, St. John's wort again, a high fiber diet that can reduce the effectiveness of these medications. And we'll also talk about some diuretics in class, and these can deplete potassium if they're not the potassium sparing variety, and can also contribute to higher blood glucose, BUN, and creatinine. Grapefruit and grapefruit juice. So I just sort of indicated that there's some cholesterol lowering medications that are troubled when grapefruit and grapefruit juice is consumed. In most hospitals, you cannot get grapefruit or grapefruit juice off the menu because there are so many problems with grapefruit in general. And what it does is it inhibits the metabolism of these drugs, which leads to toxicity in the liver. So in this case, too much drug. Warfarin and Coumadin, we talked about this, keeping your vitamin K rich foods like green leafy vegetables constant. And you can check out this handout if you want. A couple more opiates. We know pain relief, but comes with the side of constipation, and it can be quite severe. Corticosteroids, so anti-inflammatory medication, will increase blood glucose. Antibiotics often can lead to diarrhea. Metoclopramide or Reglan will speed the GI transit, and so again, depending on how long we need the drug to sort of be in the system, that can be a problem. And then laxatives often will decrease serum potassium. So take-home messages for this are what you need to know. Look at those food-drug interactions that I talked about. Think about who might be at risk for food-drug interactions, and then review the commonly encountered FDIs that I just went over. So again, this is not your primary job as the dietitian to really keep track or make sure people are dosed appropriately, but it can help you to understand maybe why some lab values are out of whack, depending on what the medication administration looks like. And again, there may be specific instances at your facility where you are the primary educator on how to manage those food-drug interactions. So just kind of depends on where you end up working. But that's it for food-drug interactions, and I will see you in class.